Actually, let me just make sure
Sorry.
my slides are progressing. So I'm particularly excited to talk to this group today because I started my career working for the Children's Environmental Health Initiative, really focusing my research on environmental justice and disparities in maternal and early childhood health. And even though about 15 years ago I shifted away from that into biomedical informatics, that experience really grounded in me that I wanted my work to focus on responsible design and ensuring that the tools we build support all communities and all of our patients and ensure that those promises of clinical prediction and AI are really delivered to everyone that we care for in our healthcare settings. And so it's really been um, a confirmation for me that I've been able to keep that thread going. And so I was very excited about that. Um, so even though I might start with something that doesn't sound health equity, it all comes together a little bit down the road. So I want to first start by talking about clinical prediction. There's all kinds of things that we want to predict for individual decision making, quality benchmarking, um, clinical decision support for our patients and providers. Um, but we develop and publish a ton of clinical prediction models. For some health outcomes that are high priority, there's hundreds of models in the literature, and most of them never get adopted. You've probably seen a slide like this before, and there's a whole bunch of reasons for that. From design to validation to utility and deployment. But if the responsible thing to do if we're going to invest in clinical prediction is really make sure that we can deliver it and we can deliver it reliably to everyone that we're treating. And one of the biggest challenges is generalizability. Um, and so it's so difficult to generalize clinical prediction models that just a few years ago, a group that does really great work around model validation actually went so far as to say there's no such thing as a validated prediction model. And I have a bit more hopeful perspective on that. Um, but their point is really well made, which is that sort of what we've traditionally talked about when we say, we need to internally validate and externally validate a model, just and give it sort of a stamp of approval, isn't sufficient in the real world when we want to deploy models to actually impact care. And there's a whole variety of reasons for that. So generalizability is really hard because the data we train our model on or the data we validate our model on can vary quite a bit from the data that we deploy that model on. Um, and that can come from a whole variety of places. So populations can be different. Their demographic distributions, their risk factors, how they are exposed to different environmental and social risk factors, and also sort of how they access and utilize care and the patterns of their healthcare. How clinical practice works. So what treatments are available, patient and provider preferences for those treatments, um, our understanding of clinical guidelines and recommendations, and even just the workflow that patients experience as they move through the healthcare system can vary across a variety of dimensions. And then it even goes so far as just the information that we record can look quite different. So even in a connected healthcare system, we've been able to show that coding practices can be different for the same health condition, even within the same network of hospitals that are feeding their data into the same EHR system. And so there's just all this variability that can come into play and really challenge when we've learned something on one set of data, how well it works on the next set of data. And so really what it ends up meaning is that context is really what matters when we talk about validation. And so there's not sort of well, this is a validated model. The context that we're using it really matters. So things from geography. So are we developing something in maybe a northern region of our country and then trying to use it in a different geographic setting where patients are experiencing very different cultural and environmental exposures. Population. So if we develop something on adults who want to apply it to children or on a really homogenous population that was enrolled in a clinical trial, and then we want to apply it to a general population, that can harm that model's generalizability. And that's really where we can most clearly link in um, some health equity concerns, but I think that they also fall out in these other pieces. Setting can really matter. Most clinical prediction models are going to be developed currently in academic medical centers. And at least here in the United States, when we have an academic medical center, they're more likely to be in urban areas. And they also are sort of our tertiary care. they're often our tertiary care providers. And so the most highly acute patients end up coming there. So it's just a different patient population than maybe in a community hospital where you might want to apply a tool. And then the context that I most focus on is temporality. And so models can go quite stale because our understanding of disease and how we treat it, and our patients that we're seeing can all evolve over time. And so a model trained at one time point might not work later. And then all of these contexts interact, and that's one of the things that we'll see later in the talk. So I argue that it's not that you can't validate a model. It's not that there's no such thing as a validated model. It's that validation is really more of a process than an endpoint. And sustainability of models across different contexts is really going to become our goal. And so I just kind of reframe how we think about it and make sure that we're taking that context of how we're applying a model into account. And so this really goes into the idea of a learning prediction system. So this stems directly from the idea of a learning health system, but really applied in that prediction context. So we have a model that we're using, we're surveilling it and monitoring how it's working over time, collecting feedback, and then we use that feedback to update that model's performance so that we constantly are improving our model and making sure it's working in whatever context, over time, over space, over population. And so it's really this process of collecting evidence and adapting models to create sustainable tools for all communities. I'm going to talk about a few different dimensions of context and how we can think about making sure our models are working for them. I'm going to talk about temporality, patient populations, and deployment setting. I'm not going to talk today about the data, the research, the data environment, and the data context, the sort of idea that we often develop models in a research context and then want to use them in a production context. And there's a gap there, and some contextual dimensions that we often don't think about. It's really interesting, but in the interest of time today, I'm not going to get into that particular piece. Let's first, but what I wanted to highlight is that as we talk about these different contexts, there's luckily, I would say, a common set of approaches that we can use to adapt models across these different contextual dimensions. And they really require, ideally, a comprehensive approach to adaptation and sustainability. So there's preventive things we can do to fundamentally build more stable models. So we often think about here like causal modeling or fairness optimized learning, things of that nature. We can do preemptive things if we have teams that are maintaining that situational awareness around clinical landscapes and technical landscapes. So when we know something is coming and a change is coming down the road, we can do something to revise our model or our data pipelines ahead of time before things go wrong. And then we're really going to focus today on responsive methods. So this is this idea that we can integrate feedback in our data streams to guide that monitoring and updating process in a data-driven way. And that becomes really helpful when we start to think about having a large volume of models that we're deploying in our health systems, because we don't want to be using our teams and our human resources on models that are working well. So if we can kind of guide that process, that could be helpful. And then, of course, users are going to let us know when a model doesn't work for a particular patient population or used to work really well and doesn't work well now. But so those reactive approaches are important, but we don't want to get there, right? If we can do things ahead of time to prevent users from noticing a problem, then we're going to help to maintain that trust and promote sort of just that safety for our patients. So that's really sort of the overall approach that we want to be thinking about. So let's first start by talking about temporality and how we can maintain and sustain models over that contextual dimension. So the idea of performance drift really was well characterized in the healthcare setting by a study from 2013 that looked at the Euroscore. So the Euroscore predicts mortality after cardiac surgery and was developed on data from the late 1990s. And by about 2010, it started to become apparent that the predictions were systematically over predicting risk. And so the model's predictions were being overly optimistic. I'm sorry, the model was providing overly optimistic assessments for healthcare centers, but the predictions were too high for patients and telling them they would have been at more risk than they actually experienced. And so this deterioration was noticed over time. So it wasn't suddenly the model didn't work. It was over time the predictions got worse and worse. Um, and so this really highlighted the problem. And so what do we do when performance is deteriorating? And the Euroscore did just what most people at the time were doing, which was very reactionary. So someone notices a problem and then we fix it, typically by developing a whole new model, but sometimes through updating an existing model. And so that's what was done. Um, but this requires that we wait till there's a problem. And we probably want to avoid that. And so other teams took a more proactive approach. So the American, it's very hard for me to say this whole acronym, American College of Surgeons National Surgical Quality Improvement Program. I'm going to call it NSQIP when I mention it later because it's so long to say. They predict about 13 different post-surgical outcomes for quality benchmarking and individual decision making. But every 6 months, they completely retrain their models using the previous 12 months of data. So they're always keeping fresh, up-to-date models, but they're sort of assuming a lot about when that update needs to happen and how much data is informative for making those updates. So they're being very proactive, but not necessarily in an informed way. And so we wanted to understand if this more proactive approach, if that just worked, schedule updating, and we could just retrain models periodically, that's simple and we can do that. So we wanted to kind of explore that option. So the first thing we did, and I'm going to use this one use case that we looked at, which was mortality after inpatient stay, where we used Department of Veterans Affairs data to look at performance over time. So the US Department of Veterans Affairs runs a national healthcare system that's very different from the rest of the American healthcare system. So it is a national network of providers. All of our veterans are eligible to receive care there, and they don't pay for any care. So everything is covered. People have access to a lot of specialists and routine care that they may not have in other contexts in the US. So that's something to always keep in mind when we're looking at data from this source. But it's really nice to have a national electronic health record. So we have really long continuity of patient information over many years and a large volume of patients. So the data in this plots really comes from about 1.9 million inpatient admissions in the VA across 8 years of data. And so what we did was we built a already published model, but we rebuilt it on just 1 year of data and then applied it over time. And so the blue line here shows for a logistic regression and a random forest on that same data, how they performed over time. And this is the estimated calibration index. So lower values are going to be better. What you can see is both models are deteriorating over time. So we're seeing that drift that we were expecting. But if we just retrain the model every year on the previous 12 months of data, sort of taking that proactive approach, we get this orange line. And so for the logistic regression, this sort of seemed to solve the problem, which is great. So maybe we're fine just retraining each year. But for our random forest, this is the exact same data as the logistic regression saw. But what we find is that retraining in most years didn't improve on the first model that we trained. And in some years, like 2009, was actually performed worse than the original model. So we know that always retraining is maybe not always going to be the right approach, and that maybe every year isn't something we want to be doing. So we needed a more data-driven way to think about this. So we came up with this idea of a surveillance framework that uses data-driven methods to monitor and maintain our models. And this stems directly from that learning prediction system idea from a few slides ago. And we wanted everything that we do to be very flexible and generalizable. So I don't care where the predictions come from. What's the underlying learning algorithm? Doesn't matter. Even as we start to think about using large language models to support clinical prediction tasks, as a number of groups are trying to sort of figure out and guide everything that I'm going to talk about, those predictions could feed into here as well. So we want to be flexible in that way. And then I really focus on maintaining calibration. So I'm going to talk about calibration quite a bit. And I do that because I think it's most tied to decision making. And if you can stabilize calibration, a lot of other metrics sort of fall out from that. And it makes numbers really ground them in meaning. So if a model tells you, here's 100 patients that are at 20% predicted risk of experiencing an outcome, about 20 of them would have that outcome. And so that 20 becomes meaningful. And so I really focus on calibration here, but anything could be substituted in. So the idea is that we have a prediction model that's delivering predictions to some kind of clinical application. And then in the background, we're constantly maintaining an up-to-date sense of that model's calibration or some kind of prediction error. We have some kind of a detection system that's looking at that error stream and that distribution over time and determining when we're seeing important deviations from that original error distribution. And if so, we're going to detect that drift and alert and let somebody know, and then provide a cohort that says, here's a cohort of recent data that seems to look different and might be particularly useful for adjusting the model to the new context. And then, given that there's a bunch of ways you can think about changing and updating a model, provide a testing approach that will recommend a particular update that's going to generalize well to the next patients we see, and sort of guide that process in the background using some data so that model managers don't have to get in there unless we're unable to restore performance. So I want to first talk about how we pick the different updating methods we're going to choose. So there's a lot of things we could do. We could just say, well, you know what, the original model is good enough. Yes, it's drifted, but it's not that bad, and we're going to maintain it. There's a variety of sort of different levels of recalibration we could think about doing. We could retrain the model, which we've seen. We could revise the entire model and come up with some new predictors or take things out, all sorts of things. And these are increasingly complex. And so what we wanted to do is come up with a way to choose between updates. And for our decision making, we emphasized making conservative choices and adapting models the least that we could to get performance restored. So we preferentially wanted to pick simpler updating approaches. And so we developed this testing procedure that uses a two-stage bootstrapping approach, And all you have to provide it is an updating cohort for training those updates and an ordered set of updating methods to consider. And I'm not going to delve into each of the steps in detail just in the interest of time. But basically what we're trying to do here is account for both overfitting in the training of our updates, and then also account for the variability in the sample size of our training updating cohort, because we might have a lot of data for updating or might have a little. And so we wanted to sort of account for some of that. And then what we're going to do is provide the simplest update that doesn't compromise performance that something more complicated could have provided. So if refitting provided the best performance on whatever performance metric we want to optimize here, we use the prior score, but you could use something else. If refitting did the best, but intercept correction was not statistically different than retraining, we wanted to recommend intercept correction because it was a smaller change to the overall model that's deployed. And so that's how we were self-guiding that updating process. And we were able to show that this was an efficient way to select updates that restore performance without making more complicated adjustments. And so if we applied that again to that same model we saw before, this is that 30-day mortality after inpatient stay model in the VA. And now we have a green line added. And here the green line is that annually we applied that testing procedure and did whatever update it recommended. And so we're able to even further improve that logistic regression performance, and we were able to stabilize performance for our random forest compared to annual refitting, which was great. But these vertical dotted lines are the only times the model actually recommended that we change anything. And so even though we ran the testing procedure every year, we only actually changed things 2 or 3 times. And so as we think of a health system deploying dozens or hundreds of models, we don't need to be testing model tools that are working well, right? If a model's working well, let's leave it alone and let's focus on those that really need it. And that drove us to this idea of needing to detect the deterioration before we start looking at updating options. So we wanted to monitor calibration using calibration curves, but we didn't want to make assumptions about how often we refit those curves, what our look back window was to inform those curves. And so we came up with this idea of dynamic calibration curves. And what these do is we fit our logistic calibration curve, so predicted probabilities against observed outcomes, which ideally is on that dotted line, which is where the red, curve starts. And then we use stochastic gradient descent and adaptive learning rates so that as new prediction outcome pairs arrive in our system, we can evolve the parameters of that logistic curve to reflect changes in the calibration context the model is experiencing. So if the model shifts to a darker dotted line that's lower in the plot, as we start to stream in data that reflects this new calibration context, our curve evolves to reflect what that looks like. But we know that as we see new data, this curve is going to bounce around a little bit, even if we're not seeing true deterioration in calibration. So we needed adaptive windowing or some kind of a drift detection, and we picked adaptive windowing to really tell us the change in this calibration curve is significant towards more miscalibration, and we need to potentially do something. So what adaptive windowing allows us to do is take a time series of error metrics, and we just keep adding on to the end of that. Um, and it'll say, okay, well, I have this time series of error metrics. If I divide it into a window of recent data and older data, and then test to see if there's a difference in the error distribution. If there's not, it's going to shrink that more recent window and grow that older window and run that test again until it finds, there's no difference in this distribution, or here's a window of recent data that looks different. And that's when it alerts to drift if a window of recent data looks different. And so what we wanted to know is, are we only detecting deterioration when it happens? And are we returning a window of recent data that's from the new context? So after the drift started, because we don't want to update our model on old data from the previous context. We want it to reflect data from the new context and the fresh current setting. And so we ran some simulation studies where we injected miscalibration into our stream of predictions at different speeds and degrees of miscalibration. And what we were able to show is that with dynamic calibration curves and the adaptive windowing drift detector, the orange bars at the bottom of this plot is the distribution of detection points. And what those highlight is that we had very few false alarms. So we were only detecting drift after it was injected into the data stream, which was reassuring. And the green boxes are the window of data that was returned when that drift was detected. And what you see is that they stop, even with the abrupt change, before later in the data stream, than when that drift was injected. And so we're returning a window of data that might be relevant to the new calibration context and might be relevant for updating. So all those methods together gave us everything we need to make this system work and maintain performance over time. And so here I'm applying it again to that third mortality model. Now it's monthly performance instead of annual, so it's just a little bit more hectic and messier. But what we were able to see with that green line, that's the surveillance-based approach at the bottom, we were able to get more stable calibration and better calibration over time than that predefined annual befitting or maintaining our original model. And we were able to do that with just a few interventions. So these red dotted lines are the only time points that the surveillance-based approach intervened and adapted the model. So we were able to keep the model up to date without doing too much to it. And again, we never refitted here. We just recalibrated a couple times. So that gave us sort of this temporality context. The next question we had was, well, if we can maintain performance for the whole population, what is that doing for subpopulations? So we know that there's increasingly recommendations that we evaluate algorithmic fairness. When we develop a new model, we want to publish it and get people to use it and initially validate it. But there's sort of no reason to assume that algorithmic fairness is not going to drift over time the same way other metrics of performance do. We didn't really have any data on the topic, and we really didn't know how fairness metrics might interact with sort of these population-based model monitoring and maintenance strategies that we've been coming up with and using in our system. And so to explore this, we went back to the VA to look at veteran data. So we had about 1.8 million surgical cases, and we used over 11 years, and we used those NESQIP quality models for mortality, readmission, and pneumonia in the 30 days after the surgery. And we wanted to look at how their fairness might have changed over time, sort of in this national cohort. So we used 1 year of data, that was our 2013 data, to develop random forest models using the NESQIP model recipes, is what I'll call them. So all of the predictors and features that they included. We developed those models, and then we applied that over the next 10 years. That was one of our prediction pathways. The other pathway was we took those prediction models and then applied our surveillance-based approach to monitor and evolve those models over time, and applied that evolving process over the next 10 years. And so for each of these paths, we evaluated performance every quarter for the whole population and by self-reported race and self-reported sex. we operationalized fairness here. There's a whole bunch of ways we could do that. For this analysis, we operationalized it as the gap between the metric in the traditionally disadvantaged group and the traditionally advantaged group. So here that would be between our Black veterans and our white veterans and our female veterans and our male veterans. And so we looked at how that might be changing over time. So just to level set and make sure that the data set's working as we expected, the first thing is our calibration. Again, lower values are better over time for the readmission model. And what we see is that the original model in gray drifted over time, which is what we sort of have expected based on all of our experience. And updating with the methods that we've just discussed was able to stabilize its performance. So reassuring is sort of everything sort of working the population level the way we expected. But what about when we think about that fairness? So we notice a number of patterns, and we're just going to highlight a few of them today. So in some, so the dotted line on all of these plots is 0, and that's what ideal gap between the two different subpopulations would be. So in some cases, fairness didn't drift. So here in gray, that's the original model's fairness gap over time. There's no trend here. There's just some variability. And for this particular model for pneumonia by race, we actually saw that population updating didn't affect this fairness over time. So we were maintaining overall performance, and fairness wasn't deteriorating or drifting with or without updating. So that was great. That's refreshing and reaffirming that maybe this is an okay strategy. But we also saw instances where fairness was actually increasing. So here at the magnitude, there's a trend towards a larger gap over time. And in this context, for this particular example, population level updating actually fixed this trend. So it corrected that fairness gap, brought it back to its original levels, and there's no temporal trend now over time in that fairness gap. So keeping performance stable and fairness stable. Okay, if that original gap is acceptable, then that's great too. But we also saw some other patterns. So here, our fairness gap's increasing in magnitude. We're pulling away from that 0 ideal value. And fairness and population level updating didn't affect the fairness drift at all. The drift that we were seeing in the original model for fairness stayed around even after we maintained that overall performance for this particular model. So that's not making the problem worse, but it's not really helping this dimension of performance. So that could be concerning. We also saw examples where fairness didn't drift. So here on the left, we have the same plot as before. Fairness is variable, but consistent over time. And that's because, as you can see on the right, even though we're seeing drift of the original model for both our male and female patients, that drift is kind of parallel between the two groups for most of the time period. So that fairness gap is sort of being maintained even as both deteriorate over time. But for this model, when we updated at the population level, what we found is that we actually exacerbated that fairness gap. And that even as we stabilized performance. And that's because we were able to get that male performance here with the green dotted line really stabilized and improved. And we didn't see as substantial improvements for our female patients. So even though we stabilized their performance, that gap is actually larger than the original model's gap. And there's a number of reasons that we could explore for that. The dominant reason here is likely that in our veteran population, 90% of our data is males. So when we're updating the model, we're really driving it towards optimizing for that male population. Yes. And so we're sort of leaving a little bit on the table for our female patients who don't seem to be as well served by that model. So that's really not what we want to be doing with our updating process. And so kind of figuring out the interactions, potential interactions between how fairness might change over time and how updating at the population level might interact with that fairness drift. We can think of these positive things where maybe we restore a gap that's increased, we restore it back to its original lower levels, but we can also see these sort of more negative interactions where we maybe exacerbate a gap or we recreate a gap that was deteriorating. And just in this one exploratory analysis, in this one use case, in this one population, we saw a lot of these patterns in our data. And so we need to explore fairness drift in more contexts and more models, but clearly just maintaining models at the whole population level may not serve all of our patients and communities equally well. And so we need to start thinking about how we manage some of those trade-offs. And that's something that we're starting to explore as well. So here I looked at demographic differences over time, but one of our um, postdocs, Asia Ruffin, is really interested in rural healthcare in the US. And so she's starting to explore how fairness across our urban-rural divide, where we know we have a lot of health disparities across those dimensions in the US, especially which vary across our regions. Um, she wanted to look at how that works over time in this national cohort. This is one of the few really truly national data sets that we would have because we're in this sort of unique healthcare system within the US. And so what she's found looking at those same models, but across urban rural, is that for mortality and pneumonia, we really don't see, we see really a pretty fair model and also not a lot of drift in that fairness over time. For readmission, however, our original model, especially starting in 2020, we started to see a lot of difference growing between our performance in our urban and rural populations. Now, updating happily corrected that for this model, but we really want to dig into understanding why readmissions are particularly affected by this urban-rural divide. There's a number of stories we could tell ourselves about what might be going on there, but one of the first things that Asia is going to be doing is really digging into the geography, because being rural in the US Southeast in our southern states is very different from being in a rural area in, say, like our frontier counties in Wyoming or Montana, which are incredibly remote and a really different population than our rural counties in, say, the Southeast or the Northeast, where you are not hours away from healthcare, but you're still pretty isolated and remote. So it can be quite different. And so we're trying to dig in and understand if some of those physical geography factors are playing into this. But thinking about urban and rural contexts and the sort of equity we might have there, I want to talk about deployment setting. So another one of our postdocs, Katie Brown, is really interested in how do we make sure that all of the technological advances, especially as we start to think about AI tools being deployed in healthcare, how do we make sure that that is being delivered to our rural hospitals, especially in the US context where a lot of our rural hospitals are not necessarily as connected to and as resourced as more urban or larger hospitals. They can be quite, especially our independent community hospitals, can be sort of left behind by technological advances in that digital divide, that's one of the places that she wants to focus. And so the first thing that we were doing with that work is she wanted to look at, if we have a network of hospitals, if we can create some relationships among hospitals, can we make sure that these models developed and usually sort of tailored to academic medical centers, how can we make sure they are delivering useful information to more remote community hospitals? And so here at Vanderbilt, we have a medical center in an urban environment. And we're also sort of in different mechanisms, kind of buying up or affiliating very closely with a number of regionally community hospitals and bringing them into our system and into our network. And so it kind of created a unique test bed for her to kind of explore how what we have running at our main hospital was working for these other populations. And so just as an easy place to start, we use the LACE Plus index, which predicts unplanned readmission and also mortality, but here we focused on its ability to predict unplanned readmission. And this is just being scored for all of our admissions and just stored in our electronic health record. So we wanted to look at how localizing that in a variety of ways might support these different patient communities. So the first thing we did was say, oftentimes we develop that model at our main site and we just deliver it, especially as we're adding new sites, we're just delivering them the tools we already have. So we recalibrated this LACE Plus model to our main site hospital, and then we just applied it to each of our community hospitals. And I'm going to have a couple slides with this plot, so I want to take a minute to describe it because it's a little complicated when you first look at it. So the x-axis is the calibration intercept, which is ideally 0, represented by that vertical dotted line. And that's sort of systematic over and under prediction. And then that y-axis, that's our calibration slope, this sort of over and under dispersion. Ideally, that's a 1 represented by the horizontal dotted line. And so ideally, we want all of our dots to fall right at that star. And you can see our blue dot representing our blue main hospital is pretty well calibrated. That's where we localize the model and it's doing pretty well. But for both of our remote sites, the model is not especially well calibrated. The types of miscalibration are different between the two, but it's not performing well for those patients we're seeing there. And so we wanted to think about, well, what if we instead put all of our data together, made some like everybody put together model, recalibrated across all of our sites together, and then applied that model everywhere. Now, this does assume that you can share data across your network. Here, we all put our data into the same electronic health record instance, so we're able to do that, but that would not be the case necessarily for all community hospitals. So that's something to consider. But so here we put all of our data together, and you may look at that right-hand plot and say, I forgot to update the graphic, but I didn't. It's just that our main site is immensely dominating this data set. We have about 40,000 admissions a year at the main hospital that are being scored with this model, and only about 1,000 to 3,000 at our community hospitals. So this recalibrated model basically looks like the main site hospital's model. So that wasn't good enough. So we asked, well, what if we just let each site do their own thing? Let everybody recalibrate the model on their data, and then it applies to their patients. And so that should be great. And we did see improvement. So that main site model, the same as before, right? But our 2 remote sites, we improved their calibration from the prior slides, but we also have a lot of variability, right? And that's because they don't have a lot of data to support the recalibration process. When we look at some sample size recommendations and apply them to this model, we actually need about 15,000 observations to do a good job recalibrating this model. And we only have about 1,000 or 3,000, right? So we're not getting the performance that we want at those local sites. We're still kind of leaving them behind. So the next approach that we've considered is data augmentation. And the simplest approach to that would be to allow sites to oversample locally to get enough of a sample size to support that recalibration. Now, if we do that at our hospitals, our blue site goes away because it doesn't need to do any oversampling. But our gray and our orange site, we do improve their calibration compared to the first model we looked at. But particularly for that gray hospital, we just have so much variability. This is not an effective approach for them to get a good model that's performing well for their patients. And that's because we're sampling 15,000 observations by resampling only 1,000. So we're just really overfitting to those observations. So we know we need to think about data augmentation in additional ways. And Katie is currently working on doing some synthetic data generation where we have a combined generator and do conditional sampling for each site, but have the power to learn from everybody's data to generate that synthetic data, but also allowing each site to have their own synthetic data generator and trying to figure out how we might be able to support these local sites in recalibration. But making sure that we're also considering some of the analytic resources that might take and what that requires of different hospital systems and different that have maybe fewer resources for computation. So as she works on that, we're also starting to explore sort of this idea of, here we've been looking at main site performance, but and sub-site performance, but what about fairness? So we found that our main hospital's performance was good, and we were able to create a pretty fair model across race and sex dimensions. But when we delivered that model to the subsites, as we saw, performance deteriorated, but we were also seeing that the fairness gaps increased as well when we moved that main site model to those satellite sites. So fairness as part of this localization process is something we need to consider. But one of the challenges there is that we already know these small sites don't have sufficient sample sizes to do their localization. And so when we've started to think about fairness-aware localization, maybe sort of incorporating those population dimensions into the localization process, we're actually making those sample sizes dwindle even more when we start to further subdivide And so what context dimensions do we consider and how do we integrate those in the trade-offs with overall performance? It's something that we're sort of digging into and working on as our next steps there, and are really excited to make sure that we can deliver tools to all of our wherever people receive their care, and whatever subpopulations they might be part of, so that we are really making sure we're delivering on these for all of our patients and all of our communities. But there is a lot to be done still. So um, as we think about developing effective, sustainable, and equitable clinical prediction tools and actually deploying them in impactful ways, there's more metrics that we need to work on developing. So everything that we have focused on is about statistically significant changes in performance, but that's not the same as clinically meaningful changes in performance. We know that. Um, and changes in clinical utility are things that we also sort of need to start thinking about detecting those changes. And how do we detect changes in fairness and use that in conjunction with our overall performance detectors to really think about maintaining fairness over time and space. And then we really need new tools to support those smaller organizations and populations, really integrating fairness-informed updating and localization, as well as how we think about integrating the feedback problem when we have effective tools that might be impacting the data that we're seeing to help with that model updating, and how we think about that, especially if impact is not the same across different subpopulations. And then we also just need like broader guidance and recommendations. You know, a lot of us are kind of sort of flying blind here. We know we have to be monitoring and sustaining our tools, but we don't have a lot of really concrete best practices for that. And so as larger medical centers are really digging in and making monitoring part of their system, we need to use the lessons that they're learning to make sure that we can come up with some generalized recommendations to more broadly support the diffusion of that technology and that monitoring approach to support hospitals that aren't part of those main medical centers. And also thinking about how we make sure that we fairly think about and responsibly think about when sunsetting needs to happen. And what do we do if a model fairness can be restored, but performance can't, or performance can be restored and fairness can't. So it gets very complicated as we think about these multiple contexts interacting. And so providing some recommendations and guidelines as people start to deploy and make the choices about how those trade-offs work is going to be really important moving forward as well. And so we're excited to sort of help lead and move into some additional methods development in those areas as well. And I know I went through a lot of things, but that's my talk today. I'm happy to take any questions.
Thank you so much, Sharon. That was a really interesting and insightful talk, and I think you touched on a lot of things that we definitely need to be thinking more about how we're going to use these clinical prediction tools, and how to maintain and update those. So thank you so much for a great talk. I'm going to stop recording now.